ECG CRASH COURSE. Today we'll be going through the basics of pacemakers. So what is a pacemaker? A pacemaker is an electrical device that is used to treat bradyarrhythmias, so whenever the heart goes slow. You can have single chamber devices where a single lead is implanted into the heart, or you can have a dual chamber device, and this is an example of a dual chamber device where you have two leads that are implanted in the heart. So the leads will be implanted in the right atrium, and we call this our right atrial lead. And we have a lead that passes through the tricuspid valve and is implanted in the right ventricle, and we call this the ventricular lead. So the leads of a pacemaker have specific functions. They are able to sense intrinsic electrical activity. For example, in the atria, they'll be able to detect the sinus beat. They'll be able to detect atrial ectopics. They'll be able to detect atrial fibrillation. In the ventricular lead, they'll be able to detect the intrinsic conduction down the His bundle system. They'll also be able to detect ventricular ectopics as well. The pacemaker leads are also able to stimulate the heart whenever needed, and we'll explore how they're able to do that in a moment. So a pacemaker is basically, in its fundamental function is basically it behaves as a timer. So the pacemaker lead is essentially, or the pacemaker itself, is programmed to set a time limit for intrinsic conduction to occur. So, for example, the right atrial lead will set a time for the normal sinus beat to occur. If it sees it within the time frame, it won't need to pace. If it doesn't see an electrical signal, an intrinsic electrical signal, within that time frame, that timer expires, and so the right atrial lead will stimulate the atria and produce a pacing spike followed by a paced atrial beat. That signal will then attempt to go down the atrioventricular node into the His bundle system. If this is all intact, you'll get the generation of a normal looking QRS. However, if you do not have intact atrioventricular conduction, that paced atrial beat will not be able to pass down to the bottom of the heart, and so the right ventricular lead, which sets its own time limit for waiting for intrinsic ventricular conduction, will expire, and once that timer expires, the ventricular lead will stimulate the ventricular myocardium, generating a pacing spike and a ventricular paced beat. Now you might have noticed, and then the whole cycle restarts again, and then the timer restarts again. So you might have noticed that a ventricular paced beat looks fairly broad, and it is broad. It is a bundle branch block, and the specific type of bundle branch block a paced beat looks like is a left bundle branch block. So why do we see a left bundle branch block pattern in a ventricular paced beat? Well, the ventricular lead is implanted in the right ventricle, meaning the signal doesn't go down the normal His bundle system. Instead, you get the activation of the right bundle first, and this signal has to spread across to the left side of the heart in order to depolarize the left ventricle. So the left bundle is never actually used, so it's itrogenically blocked, and that's why you see a left bundle branch block morphology. And then when you look across this ECG, you can see in this case a normal sinus beat has occurred, and that's because the atrial timer never depolarized and the ventricular timer never depolarized in this case. So the patient's intrinsic rhythm was able to beat the pacemaker to the beat. So I mentioned earlier that I just wanted to quickly mention sensing. So the concept of sensing is really important in pacemakers. I'm not going to go into too much detail about it, but essentially we can program we can program the sensitivity or the ability for the leads to detect intrinsic conduction. So on this, this is the level of sensing we want, and we call this sort of level of sensing, well, I call it the Goldilocks region, where we can just see the intrinsic QRSs. If we set our sensing too high, so if we move the bar down, we start to pick up P waves and T waves. When you start picking up T waves and P waves and T waves, they start in the right ventricular lead, they start to be interpreted as extra QRSs. And if the ECG sees these as extra QRSs, it will think that there's normal intrinsic conduction. I don't need to pace because the timer never expires. Likewise, if we set our sensing to low, where we move this bar up, we don't pick up the intrinsic QRSs. And so the pacemaker becomes blinded to the heart's rhythm. And so it will just pace and pace and pace for no reason. And that can be dangerous sometimes. If sensing's confusing at the moment, it will make a lot more sense when we see some examples. So this is just a quick slide of different morphologies you'll see pacemakers make. So in this case, we see a spike preceding the P wave. So this is an atrial paced beat, and then it's followed by a normal QRS, meaning that the ventricular lead timer never expired. And this is also showing that there's intact AV conduction for this beat. In this case, we can see the P wave is not preceded by a pacing spike. So this is an atrial sensed beat. The timer never expired in the right atrial lead. However, the timer did unfortunately expire for the ventricular lead, and so the pacemaker had to step in and produce a pacing spike in the right ventricle, forming our paced beat, which looks like a left bundle branch block. And in this case, our P wave is preceded by an atrial spike, so this is an atrial paced beat, and then our QRS is preceded by a pacing spike, so this is a ventricular paced beat. So this is A pace, V pace, also known as AV synchronous pacing, because the atria and the ventricles are in synchrony. So let's explore different forms of pacemaker dysfunction. So this is our first example. We can see off the bat that we can see a P wave that is not preceded by a pacing spike, so we know this is atrially sensed. That right atrial lead never needed to expire its timer. And then we see a left bundle branch block QRS preceded by a pacing spike, so we know this is a ventricular paced rhythm. However, if we start to move across the ECG, we see these pacing spikes with nothing coming after it. So what's going on here? Well, actually what's happening is that the pacemaker has failed to capture the heart. So we call this a failure to capture. And what capture essentially means in the land of pacemakers is when the pacing lead is able to successfully produce a beat. It provides enough energy down the lead to essentially stimulate the myocardium and get it up to threshold and produce an action potential. So in this case, there's intermittent failure to capture because the energy going down that lead sometimes is insufficient. And this can occur because the person who set the program for the pacemaker set the threshold too low, or sometimes the patient's taking certain antiarrhythmics, which means that the threshold is a lot more difficult to achieve, and so the pacemaker just needs to be reprogrammed again. So let's look at this example now. So we can see an atrial beat, which is not preceded by a pacing spike. So we know this is atrially sensed, and then it's followed by a pacing spike with a left bundle branch block QRS coming after it. So this is an example of ventricular pace again, with an atrial sense. However, if we start to move down, we see this area where there's no pacing going on at all. So what's going on here? Well, in this case, this is called undersensing. No, this is called oversensing. So what is oversensing? So as I mentioned earlier, if you set the sensitivity too high, you start to pick up all sorts of crap. In this sense, what's happening is that the patient's moving their arms, so this is picking up myopotentials from skeletal muscle, and it's interpreting that as a QRS, as intrinsic conduction. So the pacemaker thinks, I don't need to pace because the heart rate's really fast, and so you see this area of no pacing, and that's just a diagram showing how you're no longer in that Goldilocks region of sensing, and how you're actually picking up other things. Sometimes in some cases the pacemaker could be picking up the T wave, can sometimes pick up the P wave, but in this case this is the patient moving their arm, and the pacemaker is actually picking up the skeletal muscle electrical contractions. So what's going on here? So you can see a P wave, a QRS, and a T wave. So this is sinus rhythm, and then we see these pacing spikes. Now that might look like a pacing spike that's preceding the QRS, but usually we see a left bundle branch block pattern, and in this case we see a right bundle branch block pattern. So that's a bit strange. If we start to move across, we see a pacing spike occurring, sort of on the T wave. Again, that's very strange. And then here we see a pacing spike within the P wave. So it looks like the pacemaker's firing off randomly, even though we have really good intrinsic conduction. So what's going on here? So we call this undersensing. And again, thinking back to what's going on, so we've set the sensitivity too low. So if we get that diagram back up, we've basically put the sensitivities too low, and so we're only intermittently picking up some QRSs, and in this case we're picking up none of the QRSs. The pacemaker is completely blind to the intrinsic conduction, so it thinks there's no intrinsic conduction, so it thinks it needs to pace because it can't see these QRSs. The sensitivity is too low. So what we'd need to do, we'd need to program this pacemaker and increase the sensitivity so that we can pick up these QRSs again. Why is undersensing really bad? Well, in this example, you can see that the pacemaker is blindly pacing, even though we have really good intrinsic conduction, and then eventually a pacing spike unfortunately lands on top of the T wave, and it creates this nasty polymorphic VT we can see here, and this is called R on T phenomenon. I can't really spell very well with this pen, but this is called R on T phenomenon, and it's when a pacing spike occurs on top of a T wave and it sends the heart into an erratic ventricular arrhythmia. And if you don't know what polymorphic VT is, check out my ventricular arrhythmia video for more information. So this is why undersensing is really dangerous. So a patient presents to A&E with palpitations and feeling really dizzy. He tells you he used to feel dizzy before he had his pacemaker fitted a month ago. So it's probably he had a previous bradyarrhythmia. You decide to do an ECG to check if the pacemaker's working. So this is the ECG. Already off the bat, we can see it's really tachycardic, which might be what's causing his dizziness. So we know that the pacemaker is functioning because if you look really closely, we can see little pacing spikes here preceding the QRS, and the QRS is a sort of a left bundle branch block looking pattern. This is called pacemaker mediated tachycardia, and that's just a zoom in of the pacing spikes, the little baby pacing spikes. So what is a pacemaker mediated tachycardia? So a pacemaker mediated tachycardia is a specific phenomenon you only see in patients with pacemakers who have really good intact retrograde conduction up their atrioventricular node. So anterograde conduction is conduction that goes from top to bottom. Retrograde conduction is really good conduction that retrograde conduction is conduction that goes from bottom to back up to the top. So in this case, this patient might have had a complete heart block, so that antegrade conduction was really poor. But for some odd reason, some patients have really intact retrograde conduction for some weird reason, and that's the basis of a PMT. So what probably happened is that a ventricular ectopic. So that's, if you don't know what ventricular ectopic is, check my ventricular arrhythmia video out. But essentially, that will have retrogradely conducted up the atrioventricular node into the right atrium, causing a retrograde P wave. That retrograde P wave is picked up by the atrial lead. That then sets off a timer for the right of the ventricular lead to wait for an intrinsic QRS. We know our right ventricle is in refractory because we had a ventricular ectopic, which is an early beat, already occur. So nothing's going to happen. That timer will expire, and so the right ventricular lead will stimulate the heart and create a paced beat, and then that's what creates our re-entry cycle, because that paced beat will then retrogradely go back up the AV node, back to the right atrium, create a retrograde P wave, set that timer off again. That timer won't go off. That timer will expire in the right ventricular lead, and then the cycle continues. So that's the basis of what a PMT, of how a PMT is formed. To fix a PMT, usually you'll call a cardiac physiologist to do some amazing programming, which will hopefully help stop PMTs from occurring. And there's all sorts of AV delays and PVARPs and TARPs that you can learn. However, this is outside of the scope of the lecture. However, this is basically the timing periods that are able to be programmed to stop PMTs from occurring. So practice time. So feel free to pause the video, work out this ECG. The answer will pop up in 3, 2, 1, 0. So this is an atrial paced ventricular sensed rhythm. So you can see that you can see a P wave there preceded by a spike, and a lot of these spikes on real ECGs are quite small nowadays, because we do something called bipolar pacing. In the old days where the spikes were really big, it's because we used to do something called unipolar pacing, and then that's followed by P wave. And then we see that successfully conducts down because we see a intrinsic QRS, a narrow QRS, which isn't that left bundle branch block morphology, nor do we see a pacing spike preceding it. So that's why it's ventricular sense. So it's an atrial paced rhythm with good intact intrinsic conduction. Feel free to pause the video, work it out yourself. The answer is going to pop up in 3, 2, 1, 0. So this is a ventricular paced rhythm with underlying AF. If you look at the baseline, you can see these fib waves. You don't really see any clear P waves. So this is underlying atrial fibrillation, and you can see that each QRS is preceded by quite a generously huge pacing spike, likely to be a unipolar pacemaker, and you can see that left bundle branch block pattern. One thing to know is that patients with AF usually don't have a right atrial lead, because they don't have any, because you can't track AF. You can't track AF because it's too fast. So we usually only put single chamber devices in for these patients. So here's a case where there's a 70-year-old female who presents to A&E with dizziness and an episode of collapse. You notice she has a pacemaker in situ, so you request an ECG to be done. Feel free to pause the video, work out what's going on. The answer is going to pop up in 3, 2, 1, 0. So this is a ventricular paced rhythm with an episode of ventricular standstill, which is this long pause here where you only see P waves, and this is likely due to oversensing, where we're picking up too much things because we've made our sensitivity too high. So it's not in that Goldilocks region. We've moved that wall down so we can see too many things. So we're picking up the P waves as well as the QRSs, and so the pacemaker's interpreting these as QRSs, and so things I don't need to pace because there's good intrinsic conduction there, when actually in fact we're just oversensing the P waves. So well done if you got that. Don't worry if you didn't. It just comes with practice. So this is our next ECG, a 56-year-old male with a dual chamber pacemaker in situ, and they present to A&E for abdominal pain. You decide to do an ECG because why not? So in this case, is the pacemaker dysfunctional? That's the question. So feel free to answer the question. Obviously work out the interpretation of the ECG as well. The answer is going to come up in 3, 2, 1, 0. So this is sinus rhythm going at roughly 88 beats per minute. So we'll stop it at that for a second. So why it's sinus rhythm, just in case you're not sure. So we can see P waves there, QRSs and a T wave. And that's what we can see. We don't see atrial fibrillation. The QRS isn't broad. It's below 120 milliseconds. And we don't see any abnormal ST changes or T waves. So this is sinus rhythm. And if you worked out the rate by looking at the RSI interval, you'd get 88 beats per minute. So it's difficult. So you wouldn't say that the pacemaker is dysfunctional in this case. And the reason why is because pacemakers are programmed with a lower rate limit. So that's the lowest rate that a pacemaker will look for before pacing, and they're usually set at 50 to 60 beats per minute. This patient's heart rate, intrinsic heart rate, is going at 88 beats per minute. So that's 30, that's like a good 20, 30 beats per minute higher than what the lower rate limit would be programmed for a pacemaker. So there's no reason for the pacemaker to pace. So the reason why we do that is predominantly for battery conservation. If we can stop a pacemaker from pacing inappropriately, it means that the pacemaker doesn't need to be changed as quickly. So just keep that in mind, that if a patient does have normal sinus rhythm and they have a pacemaker in situ, and you don't see a paced rhythm, that doesn't mean that the pacemaker is broken. So this is just an example of a pacemaker programmer. So ignore all of this stuff, but we can see here that the lower rate, so this is the lowest rate that the pacemaker will begin to pace at, is 60 beats per minute. So until the intrinsic rhythm goes as low as 60 beats per minute, the pacemaker doesn't need to pace. Things like upper tracking, upper sensing, don't worry at the moment. This is above the knowledge required for medical students. And these are, I'm just looking at here, this is these are just some other settings worth to know. So this would be our sort of energies that we deliver to the down the pacing lead, and there's our good old sensitivity as well. So I hope you enjoyed that video. I hope it was useful. Feel free to check out my other ECG videos, and I'll catch you in the next one.